طيب السلام عليكم ورحمة الله. Today we'll talk about dementia and delirium. We've started with, the um, cause and management. So we will talk about each um, cluster of disorders, or group of disorders with each other. We are done with clinical features and, differential diagnosis and so on. This chapter discusses the most common disorders associated with complaints described in Chapter 7, which you might find helpful to read first. And we are done with that. Let's start with dementia. Epidemiology. The overall prevalence of dementia is approximately 1% of the total UK population, rising sharply with increasing age. Okay, so we have prevalence of 1%. And here we have this graph that's showing increased prevalence of dementia with age. So the prevalence is about 1% in 60 years of age. Then in 70 it's about 5%. In 80 it's about 10%. In 90 years it's about 20 or even more actually. It's about 30, 40. So rising sharply with increased age. So we've talked about this figure that illustrates the increased prevalence of dementia with age. The prevalence in persons aged 65 years or over is approximately 7%. In those over 80 years is about 20%, and those over 90 years of age around 30. Okay, so in 65 it's about 7, 65 it's about 7, okay. In 80 years is about 20, no it's not. Anyways. Dementia that manifests before the age of 65 years is referred to as early onset. This arbitrary age cutoff is sometimes important when determining which service will treat a patient. Alzheimer's dementia is most common in women, and vascular dementia is more common in men. Dementia is a syndrome due to various diseases, most commonly neurodegeneration or vascular damage, as below. Alzheimer's dementia in 62% of cases. Vascular dementia approximately 17%. Combined Alzheimer and vascular, which is mixed dementia, in approximately 10%. Dementia of Lewy body is about 4%. Frontotemporal dementia approximately 2%, 20% of early onset dementia. Parkinson's dementia in 2%. Other causes of dementia is about 3%. So we are talking about 2/3 of cases for Alzheimer's. 70% vascular. Okay, anyways. About the etiology. Each type of dementia will be discussed separately. Let's start with Alzheimer's dementia. Alzheimer's disease is classified as early onset before the age of 65 years, usually familial, with relatives also affected before age 65. So we have early onset, and we have late onset or sporadic, the onset after age 65 years, either no family history or relatives affected after age 65. At present, the cause of most cases of Alzheimer's disease is unknown. It appears to be a combination of multifactorial genetic risk factors, vascular risk factors, and other uncertain environmental factors. The characteristic pathological changes are beta amyloid plaques between neurons, of course, and we have neurofibrillary tangles of hyperphosphorylated tau inside proteins. So we have beta amyloid plaques and neurofibrillary tangles. And it is unclear whether either of these changes are a cause or a consequence of neuronal damage and death. The abnormalities generally begin in the medial temporal lobe, where key structures relating to memory are located, before becoming more diffuse, resulting in generalized cortical atrophy and compensatory ventricular enlargement. Here you have these changes, So it does start with the medial temporal lobe, then generalized cortical atrophy and ventricular enlargement. Degeneration of cholinergic neurons in the nucleus basalis of Minert leads to a deficiency of acetylcholine, which can be partially reversed by some anti-dementia medications, cholinesterase inhibitors. These drugs can temporarily slow the loss of cognitive function but not reverse or ultimately prevent it. So, we're talking about degeneration of cholinergic neurons in the nucleus basalis of Minert. Okay. What about the genetic factors of Alzheimer's disease? Let's start talking about the late onset Alzheimer's disease. First degree relatives of people with Alzheimer's disease have a threefold increased risk for developing Alzheimer's disease themselves. So this is important. Threefold increased in risk. The most important gene associated with late onset Alzheimer's disease is the gene that codes a protein evolved in cholesterol metabolism called apoprotein E, which is encoded by three different common alleles: epsilon 2, 3, and 4. So we have this is the most important gene associated. So we are talking about the ApoE. Okay. Individuals who inherit one copy of ApoE epsilon 4 allele are at roughly threefold increased risk for developing Alzheimer's disease, and those with two copies are at a roughly tenfold increased risk. So one copy of ApoE, threefold risk, while two copies, tenfold increased risk. However, other environmental and genetic factors must be involved, because having two ApoE epsilon allele does not guarantee that the development of Alzheimer's disease, and many patients with Alzheimer's disease have no copies of the allele. Genome-wide association studies have identified approximately 20 genes in which the polymorphism contribute a small increased risk for Alzheimer's disease. These genes are involved in amyloid processing, lipid transport and metabolism, endocytosis, and immune response. So we have these genes that are included in or have some role in amyloid processing, lipid transport and metabolism, endocytosis, and immune response. Okay. So let's talk about early onset Alzheimer's disease. Some forms of early onset familial Alzheimer's disease are inherited in an autosomal dominant fashion. 3 genes have been isolated so far. We have amyloid precursor protein in chromosome 21, we have presenilin chromosome in chromosome 14, and presenilin 2 in chromosome 1. So amyloid precursor protein APP in chromosome 21, presenilin 1 in 14, and presenilin 2 in chromosome 1. These genes are all involved in metabolism of the amyloid protein. These autosomal dominant dementias present between the ages of 30 and 60 years, sometimes as early as 28 years of age, when there is a mutation at presenilin 1. Adults with trisomy 21 Down syndrome invariably develop neuropathological changes similar to Alzheimer's disease, by middle age, and many will develop dementia. This has been attributed to triplication and overexpression of the gene for amyloid precursor protein in chromosome 21, of course. So, hints and tips. You should be aware of 4 genes in Alzheimer's dementia: 1 in late onset Alzheimer's disease and 3 in early onset autosomal dominant Alzheimer's disease. In late onset, the ApoE epsilon 4 allele increases an individual's susceptibility to develop Alzheimer's disease. In early onset Alzheimer's disease, the possession of a mutated version of one of 3 genes, amyloid precursor protein, presenilin 1 and presenilin 2, is strongly associated with development of Alzheimer's disease. Late onset sporadic Alzheimer's disease accounts for the overwhelming majority of all Alzheimer's disease cases. What about non-genetic factors? The main environmental risk factors for Alzheimer's disease are vascular. So here we have a book that is talking about that. Okay, here we have, where's the books? Here we have this books. Non-genetic risk factors for Alzheimer's and vascular dementia. So, here we have vascular, Alzheimer, and both. Vascular risk factors like previous stroke and atrial fibrillation. Alzheimer's risk factors like head injury, low educational attainment. For both, we have smoking, hypertension, diabetes, hypercholesterolemia, previous myocardial infarct, obesity, and late onset depression. Okay, so it is unclear whether vascular insufficiency is in part causes the plaques and tangles seen in Alzheimer's disease, or whether vascular damage reduces the brain's reserve, making a given amount of neurodegeneration more likely to manifest clinically. Head injury and low educational attainment are also risk factors. Hints and tips. Neurodegeneration seems to be associated with misplaced proteins. Alzheimer's disease, dementia with Lewy bodies, and frontotemporal dementia all involve the accumulation of degeneration-resistant protein aggregates. Okay. Here we have this table that's talking about neuropathology of dementia. Here we have the type of dementia and the abnormal proteins that are involved, the macroscopic findings and the microscopic findings. We'll talk about that in a minute. Okay. About here we have some hints and tips also. The National Institute of Health and Care Excellence recommends that individuals reduce their risk of dementia in later life by quitting smoking, being more active, reducing alcohol, eating healthy, and maintaining a healthy weight. About vascular dementia. The cause of vascular dementia is presumed to be multiple cortical infarctions or many small subcortical infarctions in white matter. Binswanger's disease. Binswanger disease, resulting from widespread cerebrovascular disease. On occasions, vascular dementia can arise from a single infarct in a strategic area. As with both Alzheimer's dementia and cerebrovascular disease, vascular dementia is closely associated with increasing age. In rare cases, the disease is linked to NOTCH3, a gene on chromosome 19 involved in vascular smooth muscle cells response to injury, cerebral autosomal dominant arteriopathy, with subcortical infarct and leukoencephalopathy. Okay, so that's it. Not a gene on chromosome 19. Okay. The risk factors for developing vascular dementia are the same as for cerebrovascular disease in general. We've talked about that. We've talked about it here. Okay. About Lewy body dementias. Dementia with Lewy body and Parkinson's disease dementia are now viewed as part of a continuum with the umbrella term Lewy body dementias. So we have dementia with Lewy bodies and Parkinson's disease dementia under the umbrella of Lewy body dementias. They have the same pathogenesis, and as both diseases progress, they become increasingly similar. Both are associated with deposition of Lewy bodies, neuronal inclusions composed of abnormally phosphorylated neurofilament proteins aggregated within ubiquitin and alpha synuclein. The initial distribution of Lewy bodies probably determines which symptoms occur first and hence which diagnosis is given. Early deposition in the brainstem is thought to underlie the rapid eye movement sleep behavior disorder that often precedes the onset of Lewy body dementia by several years. Deposition in the substantia nigra with associated neuronal death result in Parkinsonism. Deposition in the cortex results in cognitive impairment and hallucinations. Okay. Familial cases of dementia with Lewy body are rare, but can be caused by mutation in the genes coding for alpha synuclein, CA, okay, and intracellular signaling protein and lysosomal processing. 15% of people with Parkinson's disease have a family history of the disorder, associated with mutations in the same genes as dementia with Lewy body, and with mutations in genes coding for proteins involved in the ubiquitin proteasome system, like Parkin. The syndrome of Parkinsonism, as opposed to the specific disorder of idiopathic Parkinson's disease, can be due to any injury to the basal ganglia, cerebrovascular disease, head injury, carbon monoxide poisoning, dopamine antagonists, including antipsychotic medications, or other neurodegenerative disorders like Parkinson plus syndrome, such as a progressive supranuclear palsy. Okay, let's get back to this table that is talking about the neuropathology of dementia. Here we have the type of dementia and then the abnormal protein for each of these, and then the macroscopic and the microscopic findings. For Alzheimer's dementia, the abnormal proteins are beta amyloid proteins and tau proteins. Beta amyloid and tau. The macroscopic findings would be generalized cerebral atrophy beginning in medial temporal lobes. Okay. Medial temporal, then to be generalized. The microscopic findings would be extracellular amyloid plaques, intracellular neurofibrillary tangles containing hyperphosphorylated tau and ubiquitin. Okay. In frontotemporal dementia, as heterogeneous collection of dementias including Pick disease and progressive supranuclear palsy, the abnormal proteins will be tau proteins, TDPs, and FUS. These are FUS fused in sarcoma protein, and TDP are TRA-DNA binding protein with molecular weight. Okay. So, the macroscopic findings in frontotemporal dementia are atrophy of frontal and temporal lobes, particularly anteriorly. Microscopic findings will be intracellular aggregates of tau, TDP, and FUS. In dementia with Lewy bodies, the abnormal abnormal protein is alpha synuclein, uh, with mild atrophy frontally. These are the microscopic findings. Mild atrophy in the frontal, parietal, and occipital lobes. Microscopic findings in this disorder are Lewy bodies, intracellular aggregates of. So these are the Lewy bodies. This is the definition of Lewy bodies: intracellular aggregates of alpha-synuclein and ubiquitin in cortex. Parkinson's disease, dementia, point prevalence of 25%, increasing with duration. The abnormal proteins, the abnormal protein is the same as for dementia with Lewy body, which is alpha-synuclein. The macroscopic findings would be atrophy of substantia nigra and locus ceruleus. The microscopic findings would be Lewy bodies, but in the brainstem mainly, or at least early on, in the brainstem nuclei. Huntington's disease, the abnormal protein is called Huntington. Okay, and the macroscopic findings will be marked atrophy of basal ganglia and often frontal lobes. And the microscopic findings will be intracellular aggregates of Huntington and ubiquitin. Okay. In CJD, the abnormal proteins would be prion protein, and the microscopic findings will be spongiform changes throughout the cortex and subcortical nuclei. Microscopically, we can find extracellular prion protein plaques, particularly in cerebellum. In vascular dementia, there is no identified specific protein in most cases, while the macroscopic findings will be some infarction, multiple small infarcts, or single large or strategic infarct. And microscopically, we can find the infarcted gray or white matter, according to the case. So that's it. This is an important table, actually. A very good one. Okay. Let's continue. If dementia occurs at the same time within a year of onset of Parkinsonism, dementia with Lewy bodies is diagnosed. If dementia occurs more than a year after well-established Parkinson disease with dementia is diagnosed. The umbrella term Lewy body dementia describes both disorders. Here we have a red flag. It's important to recognize Lewy body dementia as they require a specific management approach. Key features supporting Lewy body dementia rather than Alzheimer's dementia are these key features that support Lewy body dementia rather than Alzheimer's are visual hallucinations and Parkinsonism early in dementia, and a history of rapid eye movement sleep behavior disorder. What about frontotemporal dementia? Frontotemporal dementia are a heterogeneous group of neurodegenerative disorders associated with degeneration of the anterior part of the brain. Their pathology and presentation overlap with motor neuron disease. There are three main variants: behavioral and primary progressive aphasia, which is subdivided into non-fluent and semantic variants. So these are behavioral and primary progressive aphasia, which are subdivided to non-fluent and semantic variants. Okay. Let's not talk about that. Macroscopically, they are associated with bilateral atrophy of the frontal and anterior temporal lobes, atrophied pepper-thin gyri, known as knife blade atrophy. Okay. And degeneration of the striatum. Microscopically, three main types of intracellular inclusion body have been identified, containing mainly tau, like in PIC bodies, 30% to 50% of cases. The TAR DNA binding protein in 50% of cases are diffused in cychroma proteins in 10% of cases. Okay. Mutations in genes encoding 3 proteins account for around 60% of familial frontotemporal dementia. Tau microtubule stabilization, C9 or 72 endosomal trafficking, and progranulin, a protein involved in neuronal repair and lysosomal degeneration. Communication. PIC disease is strictly a neuropathological diagnosis requiring the presence of PIC bodies at post-mortem, but previously it was used to mean the clinical diagnosis of any type of frontotemporal dementia. So, to know that. So, PIC disease is a specific disease that causes frontotemporal dementia. Frontotemporal dementia is a clinical diagnosis. Huntington disease. Huntington disease has autosomal dominant inheritance with complete penetrance. It is caused by an excessive number of trinucleotide CAG repeat sequence, usually more than 40. In the gene encoding the protein Huntington, the length of the abnormal trinucleotide repeat sequence is inversely correlated to the age of onset of the disease. This abnormal protein is associated with neuronal death, particularly in the basal ganglia, giving rise to the distressing motor signs of the disease. What about Creutzfeldt-Jakob disease and other prion-related diseases? A prion is an infectious protein. All the prion-related dementias result in a spongiform degeneration of the brain in the absence of an inflammatory immune response, associated with the deposition of prion protein in the form of beta-pleated sheets. A number of prion diseases exist, like Sqour, prion transmitted by cannibalism of neural tissue, described in the Highlands tribes of New Guinea. Gretzmann-Straussler syndrome, autosomal dominant condition caused by mutation of prion's protein gene on chromosome 20. Scrapie in sheep and BSE, bovine spongiform encephalopathy in cattle. Okay. Most cases of CJD appears to be sporadic, affecting people aged in their 50s, although it can be transmitted iatrogenically via infected corneal transplants and surgical instruments. It presented with a rapidly progressing dementia with cerebellar ataxia and myoclonic jerks over 6 to 8 months. The electroencephalogram characteristically shows stereotyped sharp wave complexes. New variant CJD is thought to be secondary to the ingestion of BSE infected beef products. It typically presents in young adults with mild psychiatric symptoms such as depression and anxiety preceding the development of ataxia, dementia, and finally death over a period of 18 months. There are no characteristic EEG changes, although the novel variant of CJD may have a characteristic MRI picture, a bilateral evident high signal in the pulvinar, the postophthalmic region, as a result of public health measures. The incidence of this rare disorder has declined further, only affecting 1 or 2 people per year in the UK since 2012. What about HIV-related dementia? Infection with the HIV thought to cause direct damage to the brain in addition to the complications of HIV infection, such as opportunistic infections like cerebral cytomegalovirus infection, a cryptococcosis, toxoplasmosis, tuberculosis, and syphilis, and cerebral lymphoma. HIV encephalopathy presents clinically as subcortical dementia, and a neuropathological examination shows diffuse multifocal destruction of the white matter and subcortical structures. We talked about the assessment, clinical features, investigations, and differential diagnosis in Chapter 7. You can go back to that. What about the management? Unfortunately, there is no cure for any of the neurodegenerative forms of dementia. Although the prognosis is invariably continued deterioration, considerable improvements in the quality of patients' lives are possible through a variety of psychological, psychosocial, and pharmaceutical approaches. The principles of management are treating the underlying cause of, if possible, like hypothyroidism, modifying vascular risk factors, and so on, showing down the rate of cognitive decline using anti-dementia drugs if indicated, slowing down that, managing associated disorders or complications like aggression, depression, psychotic symptoms, addressing resulting functional problems like kitchen skills, financial management, and social isolation, providing advice and support for carers, advising on legal measures to prepare for loss of capacity, like power of attorney and advance statements. Let's talk about specific management strategies. We have this concept of maintaining cognitive functioning. In Alzheimer's disease or Alzheimer's dementia, we do this. We use the choline esterase inhibitors like donepezil, rivastigmine, and galantamine. Donepezil, rivastigmine, and galantamine are recommended by NICE guidelines for patients with mild to moderate Alzheimer's dementia. Up to half the patients given these drugs will show a slower rate of cognitive decline and possible improvement in behavioral and psychological symptoms. Okay, that's good. Memantine is recommended by NICE guidelines for those with moderate to severe Alzheimer's dementia. Or for those who cannot tolerate cholinesterase inhibitors. It is an NAMDA receptor antagonist, thought to reduce excitotoxic damage by blocking NAMDA receptors and preventing the influx of calcium. We've talked about that when, the series about the Stahl's book. Okay. What about vascular dementia? In vascular dementia, cholinesterase inhibitors are not recommended. So this is mentioned in NICE guidelines. Okay, cholinesterase inhibitors are not recommended. The cornerstone of treatment is preventing further strokes by ensuring vascular risk factors are optimally managed. So that's it. In mixed Alzheimer vascular dementia, cholinesterase inhibitors can be prescribed for the Alzheimer's. What about Lewy body dementia? So we will talk about Lewy body dementia and frontotemporal dementias. Lewy body dementias, cholinesterase inhibitors are recommended for this type of dementia. Rivastigmine has the most evidence of benefit in both Lewy body dementia and dementia associated with Parkinson's disease. So we are talking about rivastigmine. For frontotemporal dementia, cholinesterase inhibitors can worsen behavioral abnormalities and are not usually recommended. So this is important to know. So we can use cholinesterase inhibitors for Alzheimer and for Lewy body dementia and dementia associated with Parkinson's disease, not for vascular or frontotemporal dementia. Actually, it can worsen the case in frontotemporal dementia. Structured group cognitive stimulation programs can be of benefit in mild to moderate dementia of all types. Okay. What about reducing behavioral and psychological symptoms of dementia? Behavioral and psychological symptoms of dementia are the non-cognitive symptoms of dementia, including anxiety, agitation, delusions, hallucinations, aggression, wandering, and sexual disinhibition. If a patient develops behavioral and psychological symptoms of dementia, carefully assess for a change in their physical health, including pain. People with dementia may find it very difficult to communicate discomfort. Consider medication side effects, including constipation. Assess for depression. Consider also a change in the person's environment. Are they troubled by noise, extremes of temperature, other people's behavior, and so on? So these are, okay. Then, NICE guidelines recommends aromatherapy, massage, animal assist therapy, multisensory stimulation, or therapeutic use of music or dancing for agitation. Okay. Pharmacological treatment can be considered for disturbed behavior such as aggression or agitation that does not respond to non-pharmacological strategies and is causing significant distress or risk. Anxiolytic medications such as trazodone can be useful because of what? Because of its relatively benign side effects profile. So when we talk about trazodone can be used, but not benzodiazepines. Benzodiazepines should be avoided if at all possible because they worsen cognitive, predispose to delirium, increase fall risk, and may paradoxically disinhibit and makes more aggressive in those with dementia. So you should know that. Psychotic symptoms do not require treatment if they are not distressing to the patient nor causing risk to others. If there is felt to be significant distress, a trial of antipsychotic can be considered. Consider and document the increased risk for cerebrovascular events. Discontinue if there is no benefit within 12 weeks. Depression in dementia is managed similarly to depression in older adults, but with even more care taken to avoid anticholinergic drugs, which can worsen cognition, of course. Okay. Hints and tips. Most medications should be prescribed at lower doses in older adults. In general, prescribe according to the rule, start low and go slow. This is particularly true when prescribing psychotropic medications for those with vulnerable brains like dementia, where doses a tenth of what would be used in a younger adult can be sufficient. About legal issues. People with dementia are likely in due course to lose the capacity to be able to make decisions about their welfare and financial affairs. It is advisable to arrange power of attorney as early as possible before the person loses capacity to authorize this. They may also wish to consider an advance statement. People with dementia may lose the capacity to drive safely. and they and their carers should be advised to notify the driver and vehicle licensing agency and their insurer of their diagnosis. Red flags. Benzodiazepines should be avoided if at all possible in most patients with dementia, as they are particularly vulnerable to their adverse effects such as sedation, falls, and delirium. Remember that 50% of patients with dementia with Lewy bodies will have a catastrophic reaction to antipsychotics, even atypicals, precipitating potentially irreversible Parkinsonism, impaired consciousness, severe autonomic symptoms, and a 2 or 3-fold increase in mortality. Benzodiazepines and cholinesterase inhibitors are safe in this group of patients. This exemplifies the need to exercise caution when prescribing antipsychotics and the importance of differentiating the various types of dementia. What about the course and prognosis? The course of dementia is invariably progressive. Around a third of people with dementia live in residential care. Dementia is a life-shortening illness, directly and indirectly, because it reduces the ability to communicate and tolerate management of physical problems. Diagnosis of dementia roughly halves a person's remaining life expectancy. The average duration of survival from the time of diagnosis of a late-onset dementia is 4 years, although there is a wide range. What about delirium? The epidemiology of delirium. Most research into the epidemiology of delirium concentrate on older patients who along with infants and young children, are more vulnerable to this disorder. The prevalence in hospitalized medically ill patients range from 10% to 30%. So, the prevalence in hospitalized medically ill patients range from 10% to 13%. To 13%. To 30%, okay. Between 10 to 35% of patients over the age of 65 years are delirious on admission, and a further 10 to 14% develop a delirium during hospitalization, with the incidence increasing up to 87% in those admitted to intensive care in ICU. Patients with dementia are at increased risk for developing delirium. Up to 2/3 of cases of delirium occur in patients with dementia. What about the etiology? Delirium is a final common pathway of disturbed homeostasis. It is nearly always multifactorial. In healthy individuals, multiple severe insults are required to cause it. Okay, so it is nearly always multifactorial. In healthy individuals, multiple severe insults are required to cause it, like head injury followed by sedative medication followed by surgery. Okay. On those with vulnerable brains like dementia patients, a minor insult is sufficient, like constipation or urinary tract infection. The commonest causes are medication, most commonly anticholinergics, opiates, or benzodiazepines, or systemic illnesses, particularly infections. Okay, we've talked about that in chapter 7. Sometimes no cause is found. This does not preclude the diagnosis. Around a third of cases are viewed as preventable. The pathophysiological mechanism remains unclear and may vary with cause. Suggested mechanisms include aberrant stress response, which is neurotoxic effects of excess glucocorticoids, disrupted blood-brain barrier, allowing entry of toxins and cytokines to the brain, and impaired cholinergic neurotransmission. Hints and tips. The cause of delirium is almost always multifactorial. This means prevention and management should address multiple factors too. We've talked about assessment, clinical features, investigations, and differential diagnosis in Chapter 7. You can get back to that. What about management of delirium? Delirium can be highly addressing for patients with anxiety provoking for medical ward staff who are not experienced in dealing with agitated patients. Delirium can be highly distressing for patients and anxiety provoking for medical ward staff who are not experienced in dealing with agitated patients. It can also be very distressing for the families and friends of the patient. Fortunately, it is treatable if managed appropriately and urgently. Here we have a figure for a management algorithm incorporating recommendations by NICE guidelines. So if we have a patient with delirium, we need to find and treat the cause. We need to relieve symptoms and review legal status. Let's start with the cause and to find it and to treat it. We can do that by history, patient, notes, ward staff, relatives, GP, as many as can be assessed. And by examination, including observations, neurological and standardized cognitive tests, as much as the patient can tolerate. Cardiacs. You ask about any new drug started or old drug stopped. Investigations. Review of recent investigations and consider further investigations. And you do routine investigations like full blood count, urine electrolytes, liver function test, calcium, glucose, C-reactive protein, X-ray, chest X-ray, ECG, urine analysis. These are the routine investigations. But if indicated by history or physical examination, you can do ABG, thyroid function test, blood cultures, other cultures like urine culture, HCT, lumbar puncture, and EEG according to the case. And you do the interventions for all according to the case, ensure according to the case. But we have some interventions for all, like ensuring hydration by oral, subcutaneous or IV, ensure adequate nutrition, check for and treat constipation, check for and treat pain, encourage mobility and activity as far as possible, and allow to wander where safe, of course. So this is for the cause and to treat that cause. For relieving symptoms, we have two parts for that, the environment and some medications. About the environment, clear communication of who you are and who and where they are. Calm, consistent, reassuring nursing staff. Encourage presence of friend or family member. Quiet, peaceful room, but avoid change of room and word. Optimize sensory acuity, like glasses, well-lit room, hearing aid, and so on. Orientation aids like clock and familiar objects. So you can find it clear that we need familiar, obvious, and clear communication and environment. That's it. Okay. What about medications? Medication only if severely distressed, at high risk, or unable to tolerate essential investigations or treatment. You consider haloperidol 0.5 mg regularly plus PRM. You aim to use for less than a week with review at least daily and specify stop date. And you should consider not to use antipsychotics for patients with Lewy body dementia. Okay. Avoid benzodiazepines unless substance withdrawal. You can use that in lower body dementia if needed, of course, but you should avoid it at the first place. Avoid high doses of antipsychotic. If ineffective, use small doses more often rather than increase dose. So, frequency rather than increase the dose. Offer orally first. Consider IM if refuses. IM may need to be given under common law or Mental Health Act. Check cardiacs for drugs that may perpetuate delirium, like anticholinergics. So this is for relieving symptoms. So what about reviewing the legal status? Delirious patients lack capacity. So about the accepting treatment, you should evaluate that, and attempting to leave or use of legislation that may be required in these cases. So that's it. So let's get back to some general principles of management. These are the general principles of management. First, hospitalization is essential. Delirium is a medical emergency unless prior sealing of care discussion have concluded that this is not appropriate. Vigorously investigate and treat any underlying medical condition. Always assess medication use, including over-the-counter treatments. This is a high-yield intervention. To limit confusion and foster trust, try to ensure that the patient is nursed by the same staff consistently. Merely the physical presence of a reassuring person is often enough to calm distressed patients. Maximize visual acuity, like glasses, appropriately lit environment, and hearing ability, like hearing aid and a quiet environment, to avoid misinterpretation of stimuli. Encourage a friend or family member to remain with the patient to help comfort and orientate them. Clocks, calendars, and familiar objects may be helpful with orientation. Avoid medication unless the patient's agitation is causing them extreme distress, a significant risk to themselves or others, or preventing them from receiving essential medical investigations or treatment. Antipsychotics, especially low-dose haloperidol, are generally effective in treating delirious symptoms, in part due to their sedative qualities, but perhaps also due to their effects on the dopamine-acetylcholine balance. Olanzapine can be given if haloperidol is ineffective or contraindicated. You should check for history of dystonia or long QTC. Low doses should be given initially. For example, put 2.5 milligram. Avoid benzodiazepines unless the patient is at high risk and has not responded to haloperidol, as they tend to prolong delirium. The exception is alcohol or substance-related delirium, in which they are highly effective. The specific management of delirium tremens is outlined in chapter 20 when we talk about, alcoholism and so on. Here we have a red flag. Remember that delirium indicates the presence of a medical condition that should be managed on a medical, not a psychiatric ward. Remember this when making referrals. Course and prognosis. The average duration of a delirium is 7 days, but delirium can be prolonged for weeks or months, even after the initial insult is treated. In patients who develop delirium have an increased mortality, with around a third dying during the admission. This is unsurprising given that delirium is often a sign of severe systemic illness. Those who survive have an increased duration of admission, are at increased risk for complications such as pressure sores and falls, and are more likely to be discharged to institutional care. An episode of delirium increases the risk for developing dementia sixfold, and in those with pre-existing dementia, delirium can accelerate cognitive decline. Okay. Chapter summary. Dementia is very common, affecting around 7% of those aged over 65 years and increasing with age. The four commonest types of dementia in older adults are Alzheimer, vascular, then Lewy body, then frontotemporal. Neurodegenerative dementia arises due to abnormally folded proteins, vascular dementia due to one or many infarcts. Dementia cannot be cured, but the commonest forms can be slowed using cholinesterase inhibitors. Behavioral and psychological symptoms of dementia should be managed non-pharmacologically, whenever possible. Delirium is very common in hospitalized older adults, particularly those with pre-existing cognitive impairment, sensory impairment, polypharmacy, or who are severely unwell. Think delirium. Delirium is a medical emergency that requires prompt assessment and treatment of causes. Management of the symptoms of delirium requires environmental approaches or for all and medication for a minority. So environmental approaches for all and medication for a minority. هذا والله تعالى أعلم وصلى الله وسلم على سيدنا محمد وعلى آله وصحبه أجمعين.